highlighted inauguration of this conference hall. We extend our heartfelt thanks to Commander Navdeep Bali, Executive Director and Group CEO ClearMedi Healthcare for performing the rituals of the inauguration of this beautiful conference hall. We welcome Mr. Nagesh, Facility Director. We welcome Mr. Kiran H, Facility Director. We welcome Mr. Ram, Medical Superintendent. We welcome Dr. Priyanka Satish. Dr. Avinash, oncologist. Dr. Srinivas, physician. Dr. Srinivasan, nephrologist. And again, we welcome all of our beloved consultants and each and every one of you present here. Lighting the lamp symbolizes our core values of the hospital: hope, healing and humanity. Now I request all the dignitaries to come forward and initiate the symbol of ceremony by lighting the lamp.
ಶರಣು ಪಾರ್ವತಿ ತನಯ ಮೂರು ಶರಣು ಮೂಷಿಕ ವಾಹನ ಸಿದ್ಧಿ ವಿನಾಯಕ ನಿತಿಲ ನೇತ್ರನೆ ದೇವಿ ಸುತನೆ ನಾಗಭೂಷಣ ಪ್ರಿಯನೆ ನಿತಿಲ ನೇತ್ರನೆ ದೇವಿ ಸುತನೆ ನಾಗಭೂಷಣ ಪ್ರಿಯನೆ ತಟಿಲದ ಕಿಟ ಕೋಮಲಾಂಗನೆ ಕರ್ಣಕುಂಡಲ ಧರಣೆ ಶರಣು ಸಿದ್ಧಿ ವಿನಾಯಕ ಕುಕ್ಷಿ ಮಹಾ ಲಂಬೋಧರನೆ ಈಕ್ಷು ಚಾಪನ ಗರಿರನೆ ಕುಕ್ಷಿ ಮಹಾ ಲಂಬೋದರನೆ ಈಕ್ಷು ಚಾಪನ ಗರಿರನೆ ಸಾಕ್ಷಿ ವಾಹನ ಶ್ರೀ ಪುರಧರ ವಿಠಲನ ನಿಜ ದಾಸನೆ ಶರಣು ಸಿದ್ಧಿ ವಿನಾಯಕ.
Today, we are privileged to have Commander Navdeep Bali as our chief guest in this afternoon. I request you, sir, to address the gathering.
Good afternoon, everyone. It's such an honor to stand here before you. First of all, I welcome and thank all the doctors for sparing their valuable time of being here today, and everyone else, the staff of both the hospitals who are here. It gives me a lot of happiness today to stand in this room. I mean, I can't even recognize this room. All those who have been in this room and seen this room, what a beautiful job has been done by the people who did this. It's absolutely fantastic. So, I will take this opportunity to dedicate this conference room to all the doctors of both the hospital, the entire staff of the hospital who are going to use this conference room. From the day I joined ClearMedi Healthcare, and we used to every time ask for Charcos to give us a conference room and to, although they have been quite kind to us, but I always felt that we should have our own conference room where doctors can have academic sessions. We can call doctors from outside to do CMEs. We can have our nurses training here. We can have training of the staff here. We can do so many things. Now we have our own conference room. It's got everything. There's a remote screen. I mean, there is a good audio, video system. Enough seating for people. I mean, the ones that we want to have. And I think it's a great testament to our dedication to towards doing everything what a good hospital should have. So this conference room will be used by both the hospitals. And I was just telling Kiran just now, I think every day the conference room has to become better. You can do whatever you want to do on the walls. And I also requested him that nothing from this conference room should ever be moved out. I've seen many conference rooms, when they start functioning, you start moving the chairs, then you start moving the audio visual system, then someday something goes, and then that's the end of it. But I think this conference room will serve all of us in a very, very positive manner. I'm seeing a lot of positive things happening across both the hospitals. As you are aware, as we move towards both the hospitals integrating certain services together, I hope you know that both the emergencies are almost integrated. Both the ICUs are going to be integrated from 1st September. I hope all of you know it. The ICU team, which is right now in CMRH, is going to be the same ICU team here in this hospital also. I think you also know that last 1 month or so, I'm just giving you 1 or 2 examples, there have been very, very complex cases which have been done in both the hospitals. You are also aware that we have treated almost 118 to 120 patients on couch on a radiation machine in CMRH, which is kind of a record on Electa machine without a breakdown. I think all kudos to when Narayana Health wanted to change their machine, I think still get some time. They had choices, but I think, of course, my relationship with Dr. Shetty, and they also believe that the kind of ethical quality treatment they will get in ClearMedi, they can't get anywhere. So all the patients from NH also are being treated by Dr. Chetra today, and they are coming to our hospital. You're also aware that cardiology, we have finally been able to integrate and also have a 24/7 cover with Dr. Veenu now joining, and I think a lot of people are waiting for her to join along with Dr. Jayakumar, who was already there. So kind of it gives us a little bit of boost that we required for cardiac also. Most of the departments now are optimized as far as the equipment is concerned. Dr. Ramakrishna had a long-standing, request for certain equipment which he would have done many more things. I'm sure he's now got it. So he's also very, very happy. Overall, lot of positives. Both the units are doing extremely well now. And CMMH, it is only a start point. CMRH, we have almost reached like 75% of our capacity. A little bit more is still left, but yes, I think CMMH has got a long way to go. And since we have kind of made it that there could be specialities which are different in both the hospitals, but also integration of manpower, integration of staff, integration of a lot of things which have helped both the hospitals has already taken place. I would request now all the doctors, please make use of this hall. As many as you want to do, whatever you want to do. It's open, CMEs, the smaller conferences, you want to call doctors. And I will also request Nagesh and Kiran, whenever someone comes here, the logistics has to be perfect. Okay, that means the food, the tea, it has to be the highest standard. We can't have, that when doctors come here who are our guests, or anybody comes here for that matter, let us say you want to have some public awareness lecture, please make sure that the logistics is top of the line and use this thing. So once more, thanking everyone. And I think, one more news. Dr. Srinivasan, we had wanted for a very, very long time that our kidney transplant program should be revived. So our kidney transplant surgeon has now joined. He was here for 2-3 days talking to every one of us. He just left because he has a flight to catch. And our kidney transplant program also now will recommence. I think across the board, all specialties, I can specifically talk about, let's say we talk about CMMH, I think we will be one of the finest neuro hospitals in Mysore with Dr. Sahana and also Dr. Kunal. Then orthopedics, we started doing some very, very complex cases. He walked in at the right time, Dr. Jagdish and Harsha. And also cancer, any which way, we are known as one of the finest institutions in the country. Not only here, a lot of people talk about our doctors across. Again, same goes for our kidney, our Euro program. Dr. Kiran and Anvesh have been doing some great job. So orthopedics, neuro, cardio now we have started off, oncology anyway was there, the entire kidney diseases, internal medicine, one of the finest doctors here. I mean, pulmonology, I think in the entire Vijayanagar enclave, we are one of the hospitals which has got a DM, that kind of specialized. Our ER is outstanding. Just let me tell you, our ER to IP conversions is one of the best in complete ClearMedi in CMRH. So I think outstanding. So I mean, you name it, and I think we are at that ethical level of treatment. I think all of you are aware of my thought process of what ClearMedi should stand for. We are not going to be running on the same bandwagon as everyone does. For us, it is very important to retain that old-fashioned how a doctor should have been with a patient, and that is what is our core value. As far as ClearMedi is concerned, you are aware now, in addition to these two hospitals, we have commissioned Gwalior. Gwalior is almost at its peak, full occupancy now. Mohali, Varanasi, Noida, and I think another month or so, we will be commissioning a cancer center in Bhiwani. I will request, let's see if Dr. Avinash or somebody, Dr. Chetra, somebody can come during the inauguration, which is the cancer center inside a hospital, and the machines are already landed up there, both the LINAC and the PET-CT. And what we inaugurated right next before this, Dr. Chetra and Dr. Priyanka Kartariman, is a central planning system. So we are also thinking of having a central planning for all our hospitals from here. That means the TPS or for the radiation treatment, the plans can be made centrally here. So that is again a very, very important step. Very few institutions in the country do it, but we are one of them that is doing it. So many congratulations to all of us, to all of you, and to everyone. This should be maximized, the usage of this, and amazing things are being done in Mysore by ClearMedi, whilst retaining our ethical approach towards patients. So I thank all the doctors, and also, as I said, this should also be used by nursing training, staff training, for anything else that you want to do. You want to have some, let's say, pediatric, for children, some competitions can be held here. Now you have a place, where you can have it. A proper stage is there. Somebody can perform on the stage. Children like to do that, and whatever you want to do. So it's open, and Kiran or somebody, Kiran, who will designate, will have this room, and please make full use of it. And I thank you very much. And every time I come here, we did that today again. 30 seconds of our healthcare, which has become one of the largest and one of the finest patient awareness campaign in the country today. In 30 seconds, what we were able to do. I finished the recording in CMRH. We'll do it in CMH now. I think and my plan is after we have done for 1 year, 365 videos every day, we're going to go then vernacular. That means we're going to convert these videos into the language, local language, with a voiceover, and then give those videos to the unit, and then these videos can be used again and again and again, over and over again. We are going to put them specialty wise. So let us say somebody wants to just search videos on cancer, you can just go and search videos on cancer. Somebody wants to search videos on stroke, orthopedics, heart, you can do that, because we found outstanding traction this one. Rest, I think there are a lot of good things waiting to happen. As and when they happen, we keep telling you. But it is always a pleasure to come to Mysore. It's our finest hospitals, our finest doctors. Others I would call still catching up, new ones. But our actually soul of ClearMedi lies in Mysore, and it's amongst us. That's why for last 2 years almost, I'm completing next month. Almost every month I'm here with all of you. To spend some time. But I'm very happy to say today when I came this time, I think a lot of those things which were a backlog have got cleared up. And also, I think all of you are aware, we have a new marketing head, Chellam, who has joined. Immense experience across many areas in the country, both healthcare and pharmacy. And a lot of doctors gave a lot of positive inputs about the way we have started looking at those things which we never did. Now at least I'm seeing those things that started happening. So once more, congratulations to every one of us. Also, I want to take this opportunity to compliment team at HO. I think they are watching on the screen. So CFO, Lokesh Damania, then Soma, who was involved in this thing, Anuj, the group CEO. I think these three people, along with Lokesh Biomedical, who would be involved with this TPS center and everything. A lot of people from HO were involved in the sense. So thank you all for contributing. It's come out very beautifully. I didn't want to see it before, but now I see that it is a lovely, small, compact conference room worthy of how it should be. So once more, thank you, many congratulations, and I hope this conference room serves you all very well. Thank you so much.
Thank you, sir, for your introduction and valuable words. Moving on, we will begin our inaugural C&E session. We are delighted to welcome Dr. Veenu to our team as a senior cardiologist. Welcome, ma'am. Dr. Veenu completed her MBBS and DM in cardiology from St. John's Medical College, Bangalore, and her postdoctoral training includes a fellowship from Society of Cardiovascular Angiography and Interventions and a certification in heart failure from Heart Failure Association of the European Society of Cardiology. She also holds a fellowship in extracorporeal membrane oxygenation. Her areas of interest includes advanced heart failure, women's heart health, and burnout among health professionals. She is also served as the President of Cardiological Society of India, Mysore chapter. Outside work, she is an avid cyclist and marathon runner. Over to you, ma'am.
Good afternoon, everyone. Till the technical bit settles, I'm happy to be here as part of ClearMedi, and I'm really happy to be part of this first CMP in ClearMedi, and I'm happy that I've been given an opportunity to present here. So here's a case of a 30-year-old man with ACS and cardiac shock. Next slide. So this 30-year-old boy was actually found collapsed at home after one episode of vomiting. So he was brought to the ER. So any 30-year-old with vomiting naturally goes to the medical ICU because everybody thinks of acute GA as the first thing. So he goes to medical ICU and they find that his BP is not recordable and a lot of issues. He is unable to express anything because he's going in and out with respect to his conscious state. And they get an ECG done because monitor shows some bizarre complexes. So here we see an ECG wherein we have ST elevation everywhere. So if you can see from V1 to V6 there's ST elevation. So there's an anterolateral MI and also inferior wall 2-3 AVF has ST elevation. So as soon as I saw this ECG, I took 10 minutes to reach the hospital. And then we knew if we are not doing anything immediately, we're going to lose this patient. Next slide. The next ECG is this. It shows a complete heart block and patient is going for brady. Next slide. So I knew that two coronary arteries is definitely involved. One is RCA and the other is LAD because anterior wall MI as well as a complete heart block. So first thing I did is to put in a TPI in order to stabilize the rhythm. So what we see the wire is a TPI and this is the right coronary artery. You can see that the coronary artery is filling on top and down. In between there is a total occlusion. Next slide. So we go ahead with the thrombus aspiration. What you see, there is something going in and coming out. In the meantime, the anesthetist is putting in a rise tube, which you can see on this side, in order to give loading dose, because otherwise, whatever stents I put will thrombose. So after that, this is the view that we see. The vessel is opened up, but there are plaques. So we go ahead with the stent. Next slide. So we have put in a stent and we have fixed the RCA. So now you can see that the rhythm is kind of stable. Okay, so next slide. So next I went to the left side. So left side when I see, can you see filling defect in the LCX here? That is a thrombus. So patient has left circumflex thrombus and the left anterior descending artery is missing. So that is occluded. So this part doesn't have the blood flow. So he has all triple vessel disease. So next slide. By this time, I put in an IABP because patient was in shock in order to stabilize and then went ahead, opened the left anterior descending artery. This artery was not there initially. Opened that up with a stent and then next slide. small branches which were getting blocked also we are opening up. Next slide. So for the LCX again I didn't want to put a stent. It's a 30-year-old, already I put 2 stents. The stent I thought is not the right thing to do. So I'm just doing some thrombus aspiration. After which you can see that the thrombus is cleared. So after this is done, we can actually, in this last shot, as I'm coming out with the wire, you can see that there is vasospasm here. Okay, the vessel that was big, except for where the stent is, it's becoming small. So everywhere else also there is some vasoconstriction. Next slide. So he was off IBP on day 3. When we extubated him is when we realized he had a CVA also. Because it was a frontal CVA, he only had mild monopharesis, so we didn't realize that he had a CVA. So he recovered well and he was discharged by day 8. So only thing is, this is all, next slide, cocaine-induced vasospasm and acute coronary syndrome. So possibly if he had come early, we would have only given him some NTG and settled him off. But since he's come late, he's already thrombosed, he's developed MI everywhere. So we had to put in stents and everything. This is a case almost some 7 years back, just presenting. So he's doing well. He's not working though because he's lazy, that's all. Otherwise he's doing well. And he's not gotten back to drugs again. So I thought this is appropriate to present because we are just getting kgs of drugs from Nanjangud and everywhere in Mysore. So I thought, we can be aware of what the situation can be. Thank you.
Thank you, Dr. Venu, for the informative talk. A small announcement here regarding the cardiology department. As we know that Dr. Venu is now available for both the hospitals. Dr. Venu will be covering for both CMRH and CMMH from 9 o'clock to 1 p.m. every day from Monday to Friday, and from 1 p.m. to 5 p.m. Dr. Jaikumar will be covering the cardiac department. So both the doctors will be available on call after 5 p.m. according to the rota, which will be shared with you all. I hope this will ensure the smooth running of cardiac cases in both the hospitals. Thank you. Our next session is by Dr. Roshan Manjunath, a consultant in pain medicine and palliative care. He specializes in minimally invasive pain and spine interventions with a strong focus on cancer pain management. Welcome, sir.
We're talking regarding trigeminal neuralgia, only management part. Next slide. So trigeminal neuralgia is a chronic nerve disease. Patient usually comes with sudden electric shock-like sensations on one side of the face. Usually it presents as unilateral facial pain. And whenever pain comes, it usually stays only for seconds to minutes. Usually this affects the quality of life, and the pain score usually is 10 out of 10. Because as it affects both socio-economically and quality of life will be reduced, patient will be pushed into depression, and they will have suicidal ideation also. Usually presents at the age of 50 to 70 years old. If patient is coming early, chances of secondary trigeminal neuralgia will be there. For those patients might be having multiple sclerosis or any cerebral pontin angle tumors. So we usually do an MRI protocol to rule out secondary causes, and the majority of the cases will be having a vascular loop around the trigeminal nerve. So among females, there is 0.5% increase in the incidence. So the majority of the cases there will be compression by the vascular loop at root entry zone. So this compression will cause demyelination of the nerves, which will in turn cause ectopic impulses. So the patient will feel the touch sensation as pain sensation. Next. So usually our face is, the major sensory nerve is the trigeminal nerve. It has V1, V2 and V3. V1 is the ophthalmic branch, which covers the upper part of the face. V2 is the maxillary branch and V3 is the mandibular branch. So only the mandibular branch contains motor fibers. V2 and V1 contains only sensory fibers. Next. So usually for any case we start with medical management. So we do add-on drugs like pregabalin or gabapentin along with baclofen. If patient pain is not controlled, then we add opioids also, mild to strong opioids. So apart from medical management, surgically neurosurgeons do microvascular decompression if there is an evidence of any vascular loop around the trigeminal nerve. Less invasive is stereotactic radiosurgery where high radiation is given at the desired trigeminal ganglia. Next. So, in my department, we will be doing percutaneous radiofrequency ablation. Earlier, they used to do glycerol rhizolysis also, and the newer one is percutaneous balloon compression also. We will be discussing this first and the third procedures. Next. So, in radiofrequency ablation, we insert a radiofrequency cannula. This is a 10 cm cannula with an active tip of 5 mm. So, we will be inserting this at the desired location. Then we will allow a high frequency electric current. So, this will cause high frequency movement of ions around the desired tissue. So, thus that movement of ions will increase the temperature, which will reach to 70 to 80 degrees. Among radio frequency, there is a thermal radio frequency ablation in which we achieve temperature till 90 degrees. And a pulse radio frequency in which we keep the temperature below 42 degrees, in which neurolysis won't happen, there will be neuromodulation. This pulse RF usually we do for the V1, for which the corneal reflex will stay intact, and wherever the motor fibers are there, even diabetic neuropathy, we do pulse radio frequency for sciatic nerve and the saphenous nerve also. So, in cooled RF ablation, there will be an internally cooled mechanism in which the temperature of the electrode, that is the active tip, will be maintained below 60 degrees. But the thing is, we have to give a temperature, duration for around 5 to 6 minutes. Before any radio frequency ablation, we usually do sensory and motor stimulation to make sure we are the desired nerve and the desired territory is being ablated. Next. So this is the radio frequency ablation needle. So only the tip is active. So remaining is cover will be there. Only the tip will be the active mechanism. Next. So this is the radio frequency lesion generator which we have at our hospital. So this machine we can use for standard conventional RF and pulse radio frequency. Cooled RF is not available in this machine. Next. Next. So what we do is we usually for trigeminal neuralgia with patient presenting in V2 and V3 area, we directly do conventional radio frequency ablation. So in that we usually go next image. We usually go 2 to 3 centimeter outside the angle of the mouth. So we have to see the foramen over here. It will be just medial to mandible. Previous image. So once we enter the foramen OA, so our needle either we have to reach for the V3, V2 or V1. So accordingly we will manipulate the needle to reach the desired area and we will do motor and sensory stimulation. Next. Next. So after this, our target area is just below the sella and behind the posterior clinoid process. This is the clival line. We should never go beyond the clival line. So this is the area for trigeminal. If you want to go and simulate V1, we will go more superiorly and medially. Previous slide. So only while entering from foramen OA till we reach here, we need a high amount of opioids to control pain because this will be more painful. Once we reach the desired area, usually we use only fentanyl or little bit of propofol. Once we reach there, patient will be awake all the time. We do sensory and motor stimulation. We'll ask the patient where we are giving the current. Patient will feel numbness or a stimulation in upper middle or the lower part. So once we double confirm with the patient, then only we do radio frequency ablation. Next. Yeah. Please. Thank you.
And Dr. Sunil for your informative and very interesting sessions. Now I would like to call Mr. Market, Deputy Director, ClearMedi Hospital Mysore on the stage.
To entire Multispeciality Hospitals have a multiple conference called CCAS. So for last many years we are struggling to get the conference call, but finally we reached that point and we get a beautiful conference call. I would like to, I will not take much time and I will call to Sadiq. With non-medical aid, he is contributing a patient, he is calling the patient and he is the patients. And whatever the patients are coming and whatever the patients are doing, Lama, he is only contributing and he is only counting the patients and we are getting more patients from this channel. I would like to call Commander to hand over the program. Joshua. He is also contributing social community basis and I would like to call Yamuna, who is doing the year 2 IP conversion and 2 IP conversion. Most of the time she used to spend some time with the patient and we are getting most of the patients coming moving to IP. Thank you, sir. Thank you very much.
To conclude this enriching program, now I invite Dr. Priyanka Satish to deliver the vote of thanks.
Before that, is there anybody interested to talk about the event or ceremony, or you can volunteer and talk about the conference rooms? Anybody wants to talk about it? Okay.
Good afternoon, everyone. I would like to extend a sincere thanks to all of your beloved consultants, staffs, and everyone who are present here today for the grand opening of our new well-awaited conference room. This room is definitely more than just a space for all of us that we know. A special thank you to our chief guest, Commander Navneet Bali sir, for gracing us with his presence and for his inspiring words. We are also grateful to Dr. Veenu and Dr. Roshan for their insightful talks. A big thank you to dear Soma ji and her entire team, Dr. Rakesh, Mr. Kiran, Mr. Nagesh, Mr. Santosh, for their continued support and everyone who directly and indirectly contributed to making this a reality. And if I miss someone, thank you each and everyone who are there in the backstage, who are always behind me for everything. So thank you each and every one of the management part. That's a wrap for today's session. Thanks everyone. Lunch is now available and we hope all will enjoy it. Have a good day.
Medical superintendents of both the hospitals to form an official academic committee, because when somebody tells them, please anyone wants to speak, nobody will speak. So it has to be an official committee, and you have to fix a date for each particular department at least a monthly meeting. That's what we discussed. Monthly academic meeting, fix one day of every month, like second Saturday, third, fourth Friday, something like that. Every month, taking opinion from all the consultants, so that we can have an official academic meet where each department has to present an unique case or complicated case, or if there is nothing like that, they can present what has been done in the last previous month or anything new which has been there in the world which we can practice. I think these are the things we can discuss. I think there will be a lot of things to discuss, definitely. Okay. So I think I would tell, and Dr. Rakesh will be leading that academic committee. Thank you.
Actually, we were planning to have every Saturday at 8:30 and followed by breakfast. Any changes or anything?
Consensus.
Consensus.
Just do it.
Starts with Dr. Sana. Afternoons.
No, it should be a serious issue. You fix and you.
No structure, what he's saying. No structure.
It has to be
Exactly, and very seriously, everyone should.
We will discuss it on the group and we will.
Yeah, I think
I think we'll start with weekly sessions and then.
weekly would be too much, I think.
15 days, one fortnightly.
Fortnightly.
Monthly twice. Department.
So one last request for the group photo.